Dr. Lawrence I. Golbe is one of the world's leading clinical experts in progressive supranuclear palsy and related neurodegenerative conditions. Dr. Golbe has long been associated with CurePSP as a board member, director of clinical affairs, and head of the scientific advisory board at CurePSP. He also serves as emeritus professor of neurology at Rutgers Robert Wood Johnson Medical School, where he teaches, performs research, and has a referral practice confined to PSP and CBD, corticobasal degeneration. He's also the author of A Clinician's Guide to Progressive Supranuclear Palsy, where he emphasizes early diagnostic signs, medication options, non-pharmacologic management, and palliative care. Today, Dr. Golbe will be answering questions that were previously submitted by patients and families. In the event that we have any remaining time at the end of the meeting, we may open up the proverbial floor for some questions, but that is not a given. Dr. Golbe has a very extensive list of questions that were submitted before, and we certainly want to make sure that we get to those questions. So once again, please make sure that your videos are not activated and that you have yourself on mute. Please be aware that this is being recorded, and the recording will be made available on our YouTube channel, CurePSP TV, and also on our website. So right now, I just want to mention that we are also streaming live on Facebook. And thank you, Dr. Golbe, for being here with us this afternoon. We really appreciate your time and sharing your expertise.
Well, Joanna, thank you for setting this up. It's good to take advantage of technology, especially for a disease as rare as PSP. It's hard to get a lot of people in one room at the same time to have an Ask the Doctor. So, and even by telephone conference call, it doesn't work quite as well as a face-to-face, at least when it's my face. So I have a long list of questions here. I'll try to get to most of them. We did this a couple of weeks ago, and I had some feedback that it was an awful lot of information to take in at one time, and I kind of interpreted that as meaning that I was talking too fast and maybe a little too technically. So, Joanna, if you start to see me doing that, just zap me or something.
I'll do my best.
As we did last time, I want to start with a question regarding the COVID. The question is, I assume that patients with advanced stages of the illness are immunocompromised or otherwise at higher risk for the COVID-19 virus. Can you confirm this and perhaps expand on how patients with PSP could potentially be impacted and if additional precautions should be taken? Well, first of all, people with PSP are not immunocompromised in the true sense of the term. Their immune systems are working as well as the immune systems of anybody else of that age who is not terribly active. So there's no particular susceptibility to opportunistic infections like somebody who has, say, AIDS or is getting chemotherapy for cancer. However, when you are not very mobile, you can get things like pneumonia and bladder infections, skin infections from not moving enough. And of course, people with PSP are susceptible to those things. So additional precautions need to be taken beyond the precautions that would apply to anybody else of the same age. If somebody with PSP does get COVID-19 pneumonia, and if theirs is the type of pneumonia that makes a lot of secretions, when you have PSP, it's hard to cough. Coughing is an important part of the treatment of any kind of pneumonia. And if it's hard to cough, then it's hard to clear those secretions. So it makes it more difficult to recover from the pneumonia. In other words, if you have PSP and you have pneumonia of any kind, it's a more dangerous situation. So all the more reason to take special precautions if you have PSP. But as I say, it's not directly an immune system problem. Okay, let's start with some neurological questions now. My mother, who has PSP, was prescribed levodopa, which is the main drug for Parkinson's disease. and will be prescribed Exelon in a few weeks. That's the main drug for Alzheimer's disease. I've read mostly that levodopa doesn't have too many benefits for patients with PSP. I'm wondering if there are any certain instances in patients where it works better than others. With regard to Exelon, does it offer any significant neurologic benefits for PSP? Well, the answer is that levodopa, of course, it's in the same pill as another drug, carbidopa, which makes it work better. Levodopa helps some people with PSP modestly and not for many years, as opposed to in Parkinson's, where it helps way over 90% of people pretty dramatically, and it helps them for the entire duration of the illness, for their whole life. With PSP, it's a much more modest effect, but it's still worth trying in the majority of people with PSP. Now, why not everybody with PSP? Well, because the main thing that the levodopa helps is the slowness and the stiffness. And not everybody with PSP has that. So with my patients with PSP, I don't offer it if they don't have those symptoms, or if those symptoms are mild enough that they're not really contributing much to the person's daily disability. Now, if you are going to respond to levodopa and you have PSP, you're going to need a higher dosage than Parkinson's, about twice the dosage. And of course, it has to be ramped up gradually. There's no one dose fits all. It has to be started very low in case the person has sensitivity to it, side effects, and built up gradually over a period of maybe a month or two. With regard to Exelon, Exelon doesn't work as well for PSP as it does for Alzheimer's, not even close. I mean, levodopa works better for PSP than Exelon does. Exelon helps the thinking, the memory, mainly the memory. Most neurologists don't bother using it for PSP. I will try it when there's a major memory component to the cognitive problem. If that doesn't help after about 2 months, then it's not going to help and it should be stopped. These are symptomatic drugs. They do not do anything for the long-term prognosis of the disease. Okay, next question. Why is my husband sleeping about 18 hours a day? Sleep problems are very common with PSP, both too much sleep in the day and too little sleep at night. And it can sometimes be tough to tell the difference between the day and the night in somebody with PSP. During the day, they may be in a kind of what looks like a dreamlike state, kind of half asleep. And at night, they don't get refreshing sleep. The sleep architecture, in other words, the stages of sleep, the REM sleep is really very severely degraded. So if somebody's sleeping a lot during the day, it may be because they're not getting good sleep during the night. So you should try to improve their sleep during the night, including maybe having the doctor prescribe a sleeping pill at bedtime. That would be the first thing to try. Other things are to start doing more exercise. Sometimes if a person starts to feel sleepy, just getting up and doing some stretching can make you a little more awake, maybe drinking something a little bit sweet. So basically, it's just general maintenance of health and try to get better sleep at night. Now, getting better sleep at night is a whole lecture in and of itself. I'm not going to get into that. It's so many different reasons why you may not be sleeping well at night. Those things that are particular to PSP are, besides just the problem with the basic parts of the brain that control sleep, other things in PSP may be that the bladder is not working properly. So you may have to get up frequently during the night to use the bathroom. There may be depression. Depression and anxiety can interfere with sleep, of course. Maybe the bed partner is having trouble sleeping or has some kind of illness that causes them to wake the patient up. There could be a problem with managing secretions in the person, so that because of the poor coughing, the poor ability to clear secretions, the propensity of the person's own saliva to drip down into the windpipe. These can induce a coughing fit that can wake the person up. I mean, I could just go on with this list. So you really have to talk to your doctor or maybe even a sleep specialist about ways to improve the nighttime sleep, and then maybe that'll improve the wakefulness during the day. Okay, next question. Do you see generation of PSP patients? I think what they mean is, do you see PSP running in families? My father and grandmother have PSP. Is that environment or genetics? Yes. It's, we don't know the cause of PSP. We do know that there is a subtle genetic influence. It's not enough to cause multiple people in the same family to get the disease. But there is also some kind of external influence. You can call it environmental, something that you have to be exposed to in addition to whatever genetic predisposition you may have. So just to explain that slightly differently, there needs to be a genetic predisposition, and there needs to be some kind of external additional influence. And probably neither of them alone is enough. So once in a while, we do see pairs of people with PSP who are closely related. They're in the whole medical literature, there's maybe 15 or 20 such publications. I've published 3 or 4 myself. And they're not that hard to find, but it's not the rule, that's for sure. And we don't know what specific gene would be causing it. We have a list of about 6 genes that contribute something to that predisposition, but we don't know of any specific single gene that can cause it to run, that can cause the disease to run in a family. And of course, we don't have a genetic test. Hopefully soon. Okay, my mom has PSP and has a constant urge to urinate, but then is unable to pass urine when we take her to the bathroom. It can go on for hours where she keeps asking to go. She does not have a urinary infection. This has been checked. Okay, well, the urge to void is caused by any kind of irritation of the bladder. Of course, it's caused by fullness of the bladder. The bladder stretches out, and the tissue of the bladder senses that stretch, and that sends a message to your brain that says, hey, get me to the bathroom now. Well, any kind of sensory influence in the bladder will be perceived by the bladder as the need to void. So there are many reasons why the bladder might be irritated. There are non-infectious causes of bladder inflammation. Similarly, other things, I mean, even tumors of the bladder. I don't want to start frightening anybody, but you need to see a doctor who can check for that kind of thing. And many times this could be completely treated and cured. So I'd say that that looking for non-infectious inflammation in the bladder is the probable answer. And there may also be other types of infections that don't really show up in a routine urinalysis. The question says that the person has been checked for an infection, but the standard quick urinalysis may not reveal every type of infection. So a consultation with a urologist might be a good idea, or sometimes gynecologists do this in the case of women. Okay, my mother has noticeable effects on one side of her body. Her right, I assume this is somebody who's been diagnosed with PSP. Her right foot does not respond when she wants to move. She also seems to forget about her right hand and rarely uses it. Is it typical to see these effects on one side? Well, what you're describing here is probably what's called the corticobasal syndrome. Corticobasal syndrome which is the usual presentation of a disease called corticobasal degeneration. Now, the corticobasal syndrome can occur in other diseases too, the most common of which is PSP. So there's a form of PSP that kind of looks like corticobasal degeneration does. Now, if you take all of the people with corticobasal syndrome and just explaining to you what that is. Corticobasal syndrome, a syndrome, of course, means a collection of signs and symptoms that by itself is not a specific disease. So for example, a fever and a cough is a syndrome. It's not a specific disease. Okay, so the corticobasal syndrome consists of, for one thing, what this person was describing, which is where one hand, maybe one foot, maybe both, but on the same side become clumsy, or where the person kind of forgets how to use them or uses them in inappropriate ways. Like if the doctor says to the person, show me how to salute like a soldier, instead of doing this, they might do something like this. That's called apraxia. That's an important part of the corticobasal syndrome. Other things are little jerking movements of the muscles. Other things are very brisk reflexes when the doctor taps with the hammer. Other things are dystonia, a fixed posture of one hand, something like this. And another thing is inability to perceive the position of the limb in space. So in corticobasal syndrome, these all start on one side of the body, and it may or may not spread to the other side, or it may do so after only years. Now, of all the people with that syndrome, only about half actually have corticobasal degeneration, and the other half have other things. And the most common of those other things is PSP. And in those cases that have PSP, usually there's some other sign of PSP that's more specific, like eye movement problems. So getting back to the actual question, is it typical to see these effects on one side in PSP? No, it's not typical, but it definitely occurs in PSP. Now, having said that, there are a lot of people with PSP who do get some dystonia on one side, some posturing of one hand where it may look like this or like this, or where one shoulder is up like that. That is very common in PSP. It's almost always just on one side. And very often there's some apraxia along with it, this forgetting how to do a skilled movement that you knew at one time how to do without weakness. Okay, so that can happen in PSP very commonly. Next question. I cared for my mom for 6 years. She was bedbound and had a feeding tube, was unable to speak. Was she in pain and unable to express it? And was she able to understand what was going on? She was probably not in pain. PSP rarely causes pain, thank goodness. Sometimes it may, especially if the person has a lot of posturing of the head like this. There could be pain in the back of the neck. Or sometimes if there's some dystonia, as I showed you just a second ago, after a prolonged period of that, it can cause pain. But most people with PSP don't get pain. And if they're just sitting there in kind of a natural position with no particular abnormal positioning of their joints, then you can pretty much assume that they don't have pain in their muscles and bones. Of course, there may be other sources of pain. Maybe there's a bladder infection. Maybe there's a bed sore. So it's unlikely that this person actually was in pain. And was she able to understand what was going on? It's amazing how well people with PSP can understand things. You know, they lose the ability to formulate new ideas, lose the ability to make judgments about what's the best thing to do in a situation, but they usually understand stuff really well, especially if it's something emotional or something relatively simple. So I would say that you should assume that somebody with PSP, even though they, in the very advanced stages, even though they may not be able to move very much at all or speak, they still are able to understand. And this is an important part of maintaining their morale, you know, just talking to them and just letting them know that you're there and that you're looking out for them. Very important. Next question. My husband has PSP and his breathing seems to be getting worse and worse, but the pulmonary doctors say his lungs are clear. His oxygen saturation is good. And boy, we've all learned about oxygen saturation recently, haven't we? His oxygen saturation is good, yet he can't seem to get his air. Is this from PSP? Yes, probably is. Sometimes these Parkinsonian illnesses can actually affect the part of the brain that is responsible for regulating breathing. And the disease process can fool that part of the brain into thinking that they're not breathing hard enough. So they start to breathe harder and they feel short of breath. But breathing harder doesn't change the situation. The disease process is still there. And raising the oxygen or reducing the carbon dioxide, which is what breathing does, doesn't change that situation. It's still PSP in those areas of the brain. So that's one explanation. There's another one, which is that sometimes Parkinsonian medication like levodopa can cause slow involuntary movement of muscles, kind of a writhing movement like you see Michael J. Fox have. Well, sometimes that can affect the diaphragm, which is just a muscle, which is what makes our lungs inhale when the diaphragm as a muscle contracts. And so the medication can cause these involuntary movements of the muscle of the diaphragm, and it can cause the person to just breathe at irregular intervals. And when you breathe at irregular intervals, you don't have control over it. So it gives you the sensation that you're short of breath. And it can make other people it can make other people think that you're short of breath because you're breathing in an unnatural way. So that's the other possibility. And that would be very easily treated by just reducing the levodopa. An awful lot of people with PSP are on more levodopa than they are benefiting from. So reducing the levodopa might be a good idea anyway. Let's keep going here. My husband has a diagnosis of atypical Parkinson's. Not sure which one he has. What we mean by atypical Parkinson's is, it's a terrible word. It means that you have slowness and stiffness like Parkinson's disease, but you got other stuff that Parkinson's disease doesn't have, or you don't have stuff that Parkinson's disease does have. So it's called atypical Parkinsonism. But of course, these are their own separate diseases. PSP has really very little in common with Parkinsonism when you get down below the surface. Okay, so the question is, he's obsessed with his hobby. Is an obsession like that common in PSP? Well, when you have PSP, it can produce a repetitive thinking, repetitive movements, repetitive speech, and kind of an extension of that would be just a constant, unexpected interest in one thing all the time. Let's hope the hobby is something harmless and not embarrassing. So how do you treat this? Sometimes antidepressant medications can help. It's not that the person is depressed, it's just that those medications have other effects that can sometimes help this kind of repetitive, compulsive behavior. Another possibility is levodopa. Lots of side effects of levodopa. Levodopa can sometimes cause compulsive behavior. We see this in Parkinson's routinely. I mean, not majority of people, but it's in any Parkinson's clinic, we don't even bat an eyelash when we see somebody with Parkinson's who's on levodopa, especially if it's a high dose, and they are constantly, you know, they have to go into every store they pass and buy something, or they're constantly rearranging the furniture or buying lottery tickets. And this can lead to major financial problems, or gambling more seriously than lottery tickets. I once had a patient who was constantly picking his nose. His wife was going crazy. So, and when the drug is stopped, this generally goes away. So that's another possibility. Reconsider the levodopa. Next question, is mini stroke part of PSP? And are there chances to recover the speech? I assume you're talking about speech that's lost as a result of a mini stroke. Well, PSP doesn't cause strokes. It's actually a slightly more associated with high blood pressure than the general population, but not much. Parkinson's disease, on the other hand, is associated with lower blood pressure than the general population. So many strokes are not part of PSP. If someone looks like they had a mini stroke and they have PSP, most likely it's just a stroke for other reasons. And is there a chance to recover speech? Well, the answer to that would be the same as in anybody else who's had a stroke that's affecting speech. A lot of speech therapy would be needed. I've been on various strengths and frequencies of carbidopa, levodopa over the years and cannot ascertain that it's doing anything for me. What are your thoughts as it relates to PSP? Well, I mentioned that at the beginning. There's a very large minority of people with PSP where the carbidopa, levodopa does help to a useful degree, but mainly with the slowness and stiffness. Does it help? Does it hinder anything? Well, I've mentioned some side effects of levodopa. Something that I haven't mentioned is, well, two things I haven't mentioned that are worth mentioning. Now that I'm thinking about it, there's more than that. But okay, let me just mention a few other things that levodopa can cause. One is excessive sleepiness. We talked before about why is the person sleeping 18 hours a day? Well, it may be their levodopa. That can cause sleepiness. It can even cause sleep attacks, sudden onset of sleepiness. And when the person is still up and about and driving a car, this is a problem. So another thing that levodopa can do is low blood pressure. So if a person with PSP is falling, yeah, it might be the balance problem with their PSP, but maybe they're just getting dizzy from low blood pressure when they stand up. It's easy enough to test for this. Just check blood pressure lying down and then standing up. And it's easy to treat. All right. Let's proceed. My dad's eyelids seem to be weak. I'm not sure if there's any medication that would help. Okay, weak eyelids. I guess what you mean is that the eyelids are droopy. They're mostly closed. This is a very common thing with PSP. It's not that the eyelids are weak. It's that there is an involuntary tendency to close the eyelids. And as with many other involuntary muscle movements in movement disorders, a little injection of Botox can be just what the doctor ordered. Botox in the eyelids, you say? Well, yes, it's just a very tiny, fine needle. Can just inject it in a few points around the eye. And this can relieve this drooping of the eyelids. Of course, there are other reasons why eyelids might be droopy. It might be a problem with weak nerves. It could be myasthenia gravis, Of course, myasthenia gravis is a very treatable disease. So you need to see a neurologist for this problem. Most neurologists do injections of Botox into eyelids, as do most ophthalmologists. Certainly neuro-ophthalmologists do. Okay, my husband dreams so vividly that I find him dressed to go outside in the middle of the night. Do I speak to him or just steer him back to bed? Well, there's this interesting phenomenon that happens in all of the Parkinsonian disorders called RBD. The R stands for rapid eye movements, which of course is part of the sleep cycle. RBD, REM behavioral disorder, rapid eye movement behavioral disorder. There's abnormal behaviors during sleep. The person does not remember these when they wake up in the morning. And the abnormal behaviors can be violent sometimes. They could hit the bed partner, attack the bed partner, even to the point of causing injury. It could be the form of trying to run away from some attack. Usually there's some kind of violence or some kind of fleeing from danger involved in these behavioral attacks during sleep. It's not as common in PSP as it is in Parkinson's disease, but it still happens. Maybe 30% of patients get that. And it usually responds very well to a sedative at bedtime. We usually start with melatonin, just a natural substance that occurs in the brain that helps you fall asleep. That can usually prevent these. If that doesn't work, then clonazepam, Klonopin, which is a prescription medication related to Valium. It's a benzodiazepine. That usually helps. Of course, we start with a non-prescription medication first. So that's a likely explanation for these vivid dreams and getting up and getting dressed. Okay. Can multiple system atrophy present on MRI as extremely symmetrical demyelination of the nerves? I assume you mean the nerve bundle tracts inside the brain, not technically the nerves, which are out in the limbs. No, MSA does not do that. But if you have MSA, you might get that for some other reason. All right, here's a difficult question relating to COVID. I stopped having a health aide in our home in mid-March because of COVID. My husband has PSP and I'm physically and emotionally stressed most of the time. How can I renew some home health hours responsibly? I assume you're not asking about the bureaucratic procedure, you're asking about, is it responsible to re-invite a home health aide into the home while our lockdown is still in effect? Or should I wait out this pandemic and risk my health? Not only risking your health, but risking the patient's health, your husband's health, and maybe also risking the health of the home health aide. Very complicated question. It relates to our country's overall question of how soon, how fast do you reopen the economy? What's the price in dollars for a death prevented? It's an impossible question to ask. We still have to answer it, of course. And we do answer that every day in our public policy. If we reduce the speed limit on every street and highway to half of what it is now, we'd save a lot of lives, but at the cost of economic loss and inconvenience. So this is a question that is just something that you have to talk to people you trust, people whose judgment you trust. you know, your friends, your family, clergy person, bartender, whoever you have who gives you advice, I would have no particular expertise on this. But I can tell you that people with PSP's immune systems are no worse than anybody else's. It's just that if they do get COVID, they're going to have a much greater chance of complications because of the PSP. So maybe that little piece of information helps. My sister has PSP and now speaks in a very loud, shouting voice, unless the caregiver at the residential care home says, soft voice, soft voice. Is this a common feature of PSP? Yes, it's very common for people with PSP to speak loudly. It's just part of the speech problem. Part of it may be just that when you have PSP, you tend to be a little disinhibited in other ways. You tend to maybe say things that aren't quite socially acceptable. You may be touching things. I don't mean necessarily sexually. I mean just touching inanimate objects that have no reason to need to be touched. There can be a lot of disinhibition of that sort, and speaking loudly may be an expression of that. So yes, it's part of the disease, but of course, you should still try to ask the person to tone it down. Doesn't hurt to ask. Okay, let's keep going. Why does my wife's head bend backward? Well, this happens in about 10% of people with PSP. It was one of the first features that were described originally. It's relatively unique to PSP. There's almost no other disease that does this. It's where the person's head just is bent back like that. And as I said before, if it's constant enough, it could actually produce some aching pain in the back of the neck. It can be treated with Botox injections, but that's a lot of muscle to inject Botox into. And when you inject Botox into the neck in somebody with PSP, there can be problems because the Botox can leak around through the tissues into the swallowing muscles of the neck and weaken the swallow even further and weaken the cough, weaken the ability to prevent aspiration. And so you could get aspiration from Botox injected into the neck. So more likely, the treatment for this is muscle relaxants, although that doesn't work terribly well either, or mild pain medication like Tylenol or ibuprofen. The name of that sign is retrocollis. Collis means neck. Even people who don't have retrocollis but have PSP, usually their posture is very upright, kind of a very normal looking posture for somebody with that degree of slowness and stiffness. We're used to thinking of people with slowness and stiffness as being kind of bent over, like most people with Parkinson's disease are. So this is a good clue for the doctor that the diagnosis really is PSP, somebody with an unexpectedly upright posture for the degree of slowness and stiffness. Why do PSP patients still cough and choke even after getting a PEG tube? PEG means percutaneous endoscopic gastrostomy. That means a feeding tube that goes through the skin into the stomach and can be used for putting pureed foods or any kind of liquids into the stomach. So why do they still cough and choke even after getting a PEG? Well, that's because when there are secretions, well, two reasons. One is that when there are secretions from above, saliva, mucus dripping down, that may still drip down into the windpipe and cause coughing and choking. That's unaffected by the PEG, by the feeding tube. Keep in mind that when you have the feeding tube, it does not reduce the risk of aspiration. The purpose of putting in a feeding tube would be to improve nutrition, okay? In somebody who can't eat, can't swallow, you can improve nutrition. Of course, there's a major ethical dilemma in putting in a feeding tube in somebody with PSP. This is an important thing to discuss, because by the time somebody reaches that stage of PSP, usually the quality of life has declined quite a bit. And you have to decide whether the quality of any life that would be extended would be worth it. Do you want to prolong a life of low quality? Well, it depends how low the quality is. Depends on the person's mental state, depends on what the family wants. There may be religious issues. And so this is something where the family should discuss this with the patient while the patient is still able to make a sound judgment. I can tell you that the vast majority of people with PSP, in my experience, opt against having a feeding tube. But if a family wants it, you know, after a thorough discussion, I will help them arrange it. Why do people with PSP have hallucinations? Well, first of all, this is very rare in PSP, hallucinations. And if somebody has been diagnosed with PSP, they may get hallucinations from their levodopa, yet another side effect of levodopa, easily treated by reducing the dosage. But hallucinations in the absence of any medication that might be causing hallucinations in somebody with PSP, it's probably that the person really doesn't have PSP, most likely. More likely it's dementia with Lewy bodies, where hallucinations are a very common sign, and dementia with Lewy bodies can sometimes mimic PSP to some extent. Okay. Tingling of both lower legs and feet when sitting. No history of spine or disc problems. Well, this could be something circulatory. It still could be a spine or disc problem, even though there's no history of it. A lot of people have spine and disc problems without any symptoms for years until all of a sudden they get symptoms. Of course, something nutritional has to be considered. When you have PSP, it's very easy to get malnourished. B12 deficiency, thiamine deficiency, that kind of thing. Certain endocrine problems, gland problems can cause tingling. There are many, many reasons why nerves can get damaged in this pattern. It's called a peripheral polyneuropathy, the most common of which is diabetes. The second most common of which is alcohol abuse. And then there's things like kidney insufficiency. So this is a problem that should be addressed by the doctor. Yet another possibility is just that maybe the person is just sitting in one place for too long and they're cutting off the circulation. In other words, their legs are falling asleep. That's what we call it. But when your leg falls asleep, when some part of your body, quote, falls asleep because you're laying on it, it's because you're cutting off the blood supply to the nerves. And then when you relieve that pressure, it takes a few minutes for the nerve to regain its function once it's getting its blood supply back. So that's another possibility. Okay. Those are the ones that I have highlighted. Now I'm going to go back. It's 10 minutes before the hour.
Yeah, we maybe have time for 2 or 3 more questions here.
Oh, yeah, there's a whole chat list here. Let me see what I can answer from that.
We had one that was asking your opinion regarding the intake of lion's mane mushrooms from Scandinavian studies for assisting with PSP and aiding in neuroregenesis.
What kind of mushrooms?
Lion's mane mushrooms. Are you familiar?
Not familiar. I have
Okay.
not seen that literature. I'm guessing there is no literature, but I'd love to see it if there is.
There was another question about voice banking, but it seems that it's already been answered. So let's open up our documents. I know that somebody had asked about RT001.
Oh, yeah. Well, that's an experimental drug. It's that's a nutritional substance that addresses the mitochondrial problem in PSP, if I recall. It's going to enter clinical trials. It's not available otherwise. To me, it looks like this is legitimate. Not that I necessarily think it's going to work. It's just that it's a legitimate thing to test. This is not some kind of a snake oil with no real scientific evidence behind it. There is evidence, and it's worth testing in a proper clinical trial. And I would hope that people would consider enrolling in such a trial. I hope that answers the question.
Virginia Burton asked, my husband is having a hard time getting up from a chair. We plan to buy a lift chair. They cost from anywhere from $500 to $2,500. Do PSP patients move quickly from being unable to walk? Is it advisable to purchase chairs to help you get up?
Yes, this can be very useful. What you're talking about here, a seat lift chair. They come in manual and electric. And basically it lifts the back of the seat up. It leaves the front of the seat attached. So it just stands you up. Now, when you have PSP, there could be a problem with then wanting to walk forward very quickly, or maybe activating the chair without somebody there to make sure you're not going to fall. So as long as there can reliably be somebody there to make sure the person isn't going to fall when they get up, then okay. That may not be easy to do, though.
Thank you. We have a question here asking if you can address PBM, photobiomodulation. Are you familiar with this?
Nope.
Nope. All right. After several MRI and CT scans, lab tests, and neuropsych evaluations, our neurologist still hasn't formally diagnosed my spouse, but says PSP is most likely the case. They want to send us to a movement disorder specialist for a formal diagnosis. Is this valid and necessary?
Yes. In a word, it's always a good idea to see a movement disorder specialist, at least for the initial diagnosis, to confirm the diagnosis, because there are other things that can mimic PSP. Some of them even are pretty treatable, and certainly they would have different prognoses than PSP. You'd want to confirm it so that you would have the opportunity to enter clinical trials. And if you go to a movement disorder specialist, they may actually have a trial in PSP available at that center, or they would know someplace that does. Also, a movement disorder specialist is more likely to keep up with the latest on non-experimental treatment. In other words, if some drug is discovered to help PSP, which is already available on the market, they would be more likely to know about that. They'll keep up with the literature about the disease better than a general neurologist would. So just questions like the type I've been answering are more likely to be answerable by a movement disorder specialist than by a general neurologist. And it's always a good idea to go back to the general neurologist. I don't want to say always, because sometimes transportation can be a problem, finances can be a problem. But usually insurance will pay for visits not only to the general neurologist, but also to the movement disorder specialist, maybe once every 6 months to a year, something like that. as long as the overall number of visits per year to any neurologist don't become too frequent, then the insurer might balk. But it's good to ask the movement disorder specialist about new developments, about new symptoms that have appeared that where the general neurologist isn't sure if it's PSP or if it needs some additional workup to look for some other disease. Movement disorder specialists can usually answer that type of question.
Great, thank you so much, Larry. We have, stepping back to voice banking, could you share a little bit about what voice banking is and why it might be of interest to some people?
Okay, I have to admit, I am not familiar with this, but I can easily envision what it might be. That would be where you, while you're able to speak, you record yourself saying a lot of different words, phrases, sentences, so that after you lose the ability to speak, you can just point on a tablet or some such device in order for those fragments of speech to then be played through a speaker. I assume that's what it is.
That's correct.
Sounds like a great idea.
There are many organizations that do offer this. It would just be a quick Google search to find out what they are.
Yeah, you just, people with PSP sometimes have trouble manipulating an input device. But I would say it's general, that sounds like a great idea.
This is probably going to be our last question before we have to sign off here. Thank you everyone that participated and sent in questions. We did cover CoQ10 last time that we spoke, and we have a question here about CoQ10. During the last presentation, you indicated that CoQ10, that's coenzymes Q10, is effective in treatment of PSP. They could find a few studies, one long-term, one short-term. Both studies were probably not very well done. Should I be taking CoQ10 or at least try it, and how will we know if it's working?
Well, I do try liposomal CoQ10 in all my patients with PSP. Now, what is liposomal? That's where the actual drug is encapsulated in these microscopic little oily, fatty globules, and they're suspended in a liquid. So the liposomal form comes as a liquid, and that's the only form that's going to get into the brain in any quantities. So how do you tell if it's working? Well, a doctor would examine the patient before and after about a month or two on the drug and see if there's an improvement. Or if the patient and the family notice a useful improvement, then it should be continued. If there's no useful improvement, then it should be discontinued. It costs about $80 a month. Not a huge amount by current standards of drugs, but still it's more than you want to be paying for something that's not working.
Right. Well, it is 5:59 currently Eastern Time. I want to give a big thank you to you, Dr. Golbe, for spending the time with us this evening and sharing all this information. Thank you so much to everyone that participated in today's webinar, to everybody that gave today on Giving Tuesday Now. If you are able to make a donation to CurePSP, we do encourage you and thank you. That allows us to continue offering these kinds of webinars, support groups, and sessions. Thanks, everyone. This will be made available on our website and on our YouTube channel, CurePSP TV. And the first Ask the Doctor session is already up on there. So anything that was not covered today may have already been covered in our first Ask the Doctor session with Dr. Golbe, which happened on April 3rd, I believe, of this year. So thank you all so much. Thank you so much, Dr. Golbe.
Thank you, Dr. Golbe.
You're welcome.
And we hope to be doing this again at some point. If you have other questions that were not answered, please feel free to email them to marketing@curepsp.org. All righty. Thank you so much, Dr. Golbe. We'll talk to you soon. Thanks for all your information.
Thank you, Joanna.
Thanks everyone for logging in today. We'll see you soon. Stay safe.
Be well.
Bye.
Bye-bye.